everyone. Welcome to episode 2 of Let's Talk About It. My name is Rochelle Beard, and I am an infection prevention and quality improvement consultant based out of Louisville, Kentucky. And I'm your host for this week's episode and, well, all the episodes. So Let's Talk About It is a series where I get to sit down with my colleagues and friends and fellow IPs, healthcare workers, and then even some other professions to discuss infection prevention and then the topics and all the challenges and then overall uniqueness that can be in some of these environments. Today is no different. We get to talk about infection prevention in behavioral health and all the challenges and the uniqueness that comes with that environment. And I'm super excited to have fellow IP friend and colleague Natalie Pratt here to talk about this topic with us. Natalie, thanks for joining, and go ahead and let our audience know who you are, what you do, and a little bit about your experience in infection prevention and also how it has overlapped with behavioral health, and then also just your experience in behavioral health in general.
Okay, yeah. Thank you so much for having me. So I've been an infection control nurse for about 6 years. I will hit year 6 this July. And so I started off with no infection control experience just before COVID. And I started at a very large facility in downtown Louisville and got a lot of really good experience there. After that, we had another facility within our system that was purely a behavioral health facility, is one of the largest in our region. And so we had probably something like 300 acute beds. We had a geriatric unit that was offsite. And then we also had outpatient location as well in another area of Louisville. So I have behavioral health experience as a case manager and a nurse since behavioral health in general since 2006. My first degree is in bachelor's in psych. And then, of course, just as I went through nursing school, et cetera, I stayed in that behavioral health care world. I still currently work PRN within the behavioral health sector as a direct patient care nurse in the community. So being that I had that experience, I also had infection control experience, and there was this need. It seemed almost like the perfect fit to me.
So much experience. I'm super excited for you to be here. Before we jump in and really pick your brain, I want to just do a high level, extremely high level, because I do not have the experience that you have in behavioral health, but an extremely high level about the environment and different things that we might talk about or discuss, just so people who, like myself, aren't fully versed in behavioral health can kind of just know some key terms and be thinking on the right wavelength. If you want to jump in at any point in time, please let me know if I miss anything. So I want to cover a few key terms. We're going to talk about mental illness, behavioral health care, what is a milieu and a therapeutic milieu, and then also talk a little bit about ligature risk here and what that means. So I'm going to set the stage here. So mental illness, it's a wide range of mental health conditions that can impact someone's mood or thinking or behavior and can cause serious functional impairment that can interfere with life. So anytime mental illness is used, think of this definition here. We've got behavioral health care. So this is going to be healthcare that provides prevention and intervention, and then also treatment services in the areas of mental health, substance abuse, and developmental disabilities. I think sometimes people might just look into like the psych component of behavioral health care, but this can also be like substance abuse treatment, alcohol and drug rehab, those kind of things too. So they are not excluded in this type of behavioral health care. Milieu and therapeutic milieu. This milieu is going to be your overall therapeutic environment and then interactions of the individual with the environment. And then your therapeutic milieu is the creation of an environment that is going to promote their top safety and comfort on the behavioral health unit. So, Natalie, can you talk a little bit about these? I feel like milieu is a word that some people sometimes might just be like, oh, it's like a lobby, but that's not really what a milieu necessarily is. Can be, but is not necessarily in this setting. Could you speak a little bit to these?
Yes. So when we think of a behavioral health care facility or a unit, a lot of times in patient care, we are thinking about a patient, and that patient is in a room, for example, and they're not necessarily walking around the unit. But in the behavioral health world, the entire space is the patient environment. And so that's what I think of when I think of these terms. And so we would ideally love for it to be therapeutic, which means low stimulation. Low stimulation. This could also mean our verbal and non-verbal behaviors between the patients, between the staff and the patients. This could be ancillary staff coming onto the unit and the things that they're doing. And so the goal is to be therapeutic and provide that low stimulus environment. However, we all know as human beings, we don't all get along sometimes. And so when we think about the entire unit being their space, and they are not isolated to a room, such as in med-surg ICU, we have to remember that people don't get along sometimes. There could be factors in the environment that creates a difficult milieu per se. And so there could be aggression, there might not be aggression, there just could be arguing, there could be just different dynamics going on with different people. So I will say this, and I just to give people that work in that world some credit, it is a difficult job because you are really dealing with multiple patients at one time. It could be 16 patients, it could be 10 patients, and it could be 4 patients. And the 4 that you're dealing with, that milieu could be a whole lot more difficult than the 16 patients that you had, because it just depends on their personality, the dynamics, things that are going on. And you've got patients too that might come in paranoid, and they're already preset judging the staff that's working with them, or preset judging that person in the white t-shirt that's sitting there in the corner quiet. So I don't know if that's helpful, but that's kind of what I think about.
Yeah, it's very helpful because like I said, I think people think of the word like milieu as like an actual physical space, like something like a lobby or whatnot, but that you explained it so well that it is like that and all of the above, everything else that is in it, even the people who are in it, and to make it that therapeutic overall environment. So no, I think that was perfect. But with that environment, a little bit here, something that we always have to draw attention to when you're discussing the behavioral health environment are things that could pose a ligature risk. So this is going to be anything used to attach a cord, a rope, or any other material for hanging or strangulation. These could be pipes, shower rails, radiators, door handles, and things like that. I know we had talked about you speaking a little bit on this. What do you like to add?
And so much of my behavioral health experience was in the community. So we didn't deal a whole lot with ligature risk, nor did I deal with ligature risk in the acute care medical setting. Ligature risk could be a bolt, right?
Yeah.
Something as small as how are you securing this picture frame to the wall. Ligature risk could be, and we'll talk later about hand hygiene, but if we are to, let's say, have some kind of something put on the wall, for example, a hand sanitizer unit, that has to be built in a certain way so that people cannot hook something around it and hurt themselves. It's the hinges on the doors even, right? It's the emergency call lights in the bathrooms. If that's sometimes EDs have a behavioral health restroom and, they have to have a call light. That has to be so many inches. You wouldn't believe the amount of things that can be used to hurt yourself. One thing I did want to talk about for ligature risk, because yes, clearly we need to look at everything, including like our construction barriers and stuff like that, and we'll hit on that a little later. But I did want to say, when we look at the faucets that we're using, like our sink faucets or shower faucets, because a lot of these, they don't have like handles on them. They are, automated. So we're sticking our hand underneath, the water is coming out. That kind of slows the water flow down. So just something to think about with risk of Legionella and things like that, because it does increase the risk of Legionella.
Really putting your IP hat on there with the slowing down of the water and everything there. So great thing to point out and people to be aware of when doing infection prevention in these behavioral health units and facilities.
Yes.
So see, this is why I have you here. I want to touch on just again, high level, some infections, because we're going to talk more about this when we get into the big conversation here. But um, your infections in behavioral health are mostly going to be related to human interactions because, like Natalie just mentioned, like when you mentioned about they're not confined to their rooms, they're moving around. So that's what you're going to be thinking. These people usually are not coming in sick. They're coming in as in symptomatic healthcare illness, contagious wise. They're not coming in physically sick. They're not necessarily going to be spreading infections until like someone gets a little bit of a cold and they're walking around and hanging out in the group rooms and those kind of things. So think your respiratory, your eyes, ears, nose, mouth, any like skin lesions where you're going to be contacting, and then lovely GI bugs because those things spread like wildfire in these congregate settings. And you always hear congregate setting as like an increased risk factor for tons of illnesses, respiratory, GI, and otherwise. Anything to add to this right now, Natalie?
I do, and I'm not sure if I misunderstood what you said, but these folks come from congregate settings before they get to our hospitals. So they're coming from like homeless shelters, jails, maybe different places. So my experiences, they may not be sick, like they may not be completely immunocompromised or something like that, but they bring with them the respiratory illnesses. They bring with them the GI illnesses. And so our assessment of these folks, just as in any other acute setting where you're coming in and you're doing your screening, like any cough, it is so important, even much more important in the behavioral health setting, because now they're going to go on to a unit, which is congregate. And so our assessment and our interventions are crucial and as soon as possible. So being very proactive in this setting is even more so important to me. And like a lot of our patients, I would get this all the time when I started. Well, we're not acute. This is not a medical facility. No, it's not a medical facility. But how many behavioral health patients do you know see their doctors all the time, following up on their medical care? They're not. There's a huge gap, out there. I know because I work in the community with patients and I try to bridge that gap. But we don't know if they're immunocompromised half of the time, right? And so anyways, just some key points and things that I think about when you're talking about some of this.
Yeah, very important because with an admission history, you need to find out that are they coming from another congregate setting or are they coming from a house or like
Mhm.
a private home, or are they coming from being homeless and living on the street. So that's going to flag thinking for different illnesses they could potentially have that could be contagious
Mhm.
based on that risk factor alone of simply where they live.
Yeah.
And then also getting a really good symptomatic admission history and whatnot of if what they have coming on at admission, because if they are hacking up a lung and walking around in
Right.
the open areas, like you need to be able to, if not able to completely stop it, be able to put some mitigation measures in place to make it safe for the other people that are in the facility as well.
And I really think about tuberculosis, number one. When you work in behavioral health, you're at a heightened risk of TB patients. And now with Candida auris, right, depending on the region you live in, and me having a geriatric unit, a lot of those folks were coming from skilled nursing facilities and things like that. So that admission screening is just crucial so that you can try to like put some precautions, whether they be modified or whatever, in place to mitigate the spread or potential spread of an illness on those units.
Yeah, very good points. Lastly, just in this overall summary here, want to touch on a risk assessment and we'll dive more deep into this. You want to do a risk assessment for whether it's your annual risk assessment or basically with almost every decision related to infection prevention that you're going to make in a behavioral health facility, because you don't need to do work for something that doesn't impact your facility. What a behavioral health risk assessment is going to be totally different than an acute care facility risk assessment, just based on what we just talked about, the kind of things that you're going to see in the population where they live and those kind of things. Things are going to be drastically different. But you need to be able to see what kind of infections you're getting, look at like your building and the way things are, how old your pipes are, and all those kind of things to really determine what your risks are going to be at your specific facility. And then you also need to make sure that you have the authority to make these decisions related to infection prevention, and then also be able to implement interventions when something pops up or needs to be done. You're not ever going to have a one size fits all. For even one behavioral health facility is not going to have the same risk assessment issues as the next one that could be just like down the street. You have to take in the entire population and the environment into account. And you might be short some resources that your friends down the street do have, and vice versa. So, what resources do you have? What's safe to use for the population that you serve? What are you allowed to use per different regulations, and different things along those lines? Anything to add before we jump more in, Natalie?
No, I mean, just basically with just specifically your annual risk assessment, I right away pulled in all the different departments, engineering facilities, employee health, accreditation, nursing, like the DON or the CNO, because especially being newer at that facility, but I think in general, whether you're new or not, pulling all those people in so that you can really get a good understanding of what needs to be prioritized.
Yeah. All right. Let's dive in and talk about it. I want to talk about obviously the people that we serve and see in the behavioral health setting. We talked a little bit about the admission history and the good information we can get there. Let's see. What are some other things about the specific people who we see in behavioral health settings?
Well, I mean, basically, those areas are predominantly where we get a lot of our folks from. So off the streets, jails, homeless shelters, but of course could be a person like you or me, right? Those are the folks a lot of the times that you're seeing in these facilities. You talked a little bit about substance abuse. So sometimes with detox, we'll see symptoms of like diarrhea. You might have chills, right? So these kind of vague symptoms that may also seem like this person could have a communicable illness. They might be lethargic and so forth. So one of my biggest things with behavioral health was identify, isolate, inform. Like basically we need to be proactive. We need to be assessing patients, and if we can isolate them or keep them socially distanced from others until we know more, that is going to be ideal. You're going to have an outbreak in a behavioral health setting. It will happen at some point. But do we rather have 2 people or do we rather have 13 or 14 or 5 different units, right? So it's just trying to mitigate that. So going back to my detox patients, my nurses were on board and they're like, hey, we got someone with diarrhea. They also have chills. And then I'm like, oh, are they sick? But what we really needed to do is work together. And I did have a behavioral health background, so that was very helpful. But even if I didn't, working with your staff, working with the mental health techs, working with the nursing staff, working with whoever has the knowledge of behavioral health, and trying to get down to, so what are the symptoms of detox, and really understanding that, and then trying to help them understand like when things are communicable or not. If we don't think it's detox and we're really concerned, let's put some measures in place. And sometimes we can't like isolate the patient because they don't want to, or maybe it's a safety issue. So what are some things that we can do in the meantime, until we have things rolled out? So that's all I kind of wanted to highlight on.
I want to bring attention to that specific example where you're talking about, are they detoxing or is it a communicable disease? And then what's safe to implement for isolation precautions, those kind of things. That right there is a risk assessment that you're having to do in a scenario, basically just in your brain on the fly. And I think sometimes, especially newer IPs might miss that that's what a risk assessment is, just what you did. Talked about, is this a possibility of detox? Yes or no, but is it also a possibility of communicable disease? What's the likelihood it's detox versus a disease? And then what can we do that's safe and going to protect too? And where can we land somewhere in the middle? And that is a risk assessment just on the fly.
And I'm a very boots on the ground IP, although it may not seem so some weeks because I'm stuck behind the office working on data and all kinds of things. But to really do a risk assessment, to really make some of these decisions, you have to go visit the places. And so I was not super familiar with detox stuff because I worked in the community. So that was like one of my first places I went to that unit, looked and saw how it functions. Where's your group room? What are the symptoms? I mean, I kind of know what they are just because of having mental health experience and nursing, but I didn't work with those patients. So tell me what you all know. And let me tell you, getting the buy-in from the staff and getting out there, you don't have to get out there every day, but get out there. They know you, and talk with them. They're going to teach you so many things, and it's going to really help when you have to come down to make some decisions and maybe you can't run to the floor. You can actually say, okay, well, I know this information. I know my information, and here's, this is the best approach to take for this particular patient.
Going back to a little bit of the admission history, some things I think could probably make some people a little bit uncomfortable that they need to talk about that is especially important in this setting. But things like, and actually in any healthcare setting, things like sexual history, their at-risk behaviors, are they using drugs, which we already kind of touched about? Do they share needles? Are they having unprotected sex? These are all things that might not be top of mind in a different type of healthcare setting and is not probably anyone's favorite thing to talk about, but that definitely is something that needs to be discussed and found out when you're getting a good admission history, because again, it's going to contribute to what kind of illnesses they have, what is contagious, what treatment they need as well, because you don't want to get behind on something that if somebody is being treated for hepatitis C and you don't want to mess up their drug regimen or something like that. So also things to think of that people might not enjoy talking about very much.
Mm-hmm.
I want to move into behavioral health environment. So we talked a little bit with the environment and the therapeutic milieu, but let's talk about the group activities, different challenges, and what just overall like makes it unique in behavioral health.
Well, everyone's together. There's lots of shared items. There's lots of weird items in behavioral health, puzzles and blocks, and there can be children very young. So some of the things with pediatrics that we have to think about. So I don't know if all facilities are like this, but a lot of inpatient behavioral health, they continue to have school somewhere within that facility. So we would have kids from different units and they would go to class. And so you might have 3 or 4 units mixed up going to a class together. And so when we talk about people being sick or someone getting sick, whether it be an employee comes in and gives some patient something, or maybe somebody came in and we missed something and now things are spreading, we can potentially see multiple units with outbreaks of things because we've got these kids mixing in a classroom, sharing items, sitting next to each other, doing little group activities together. So some of the things that I learned while I was working there that has really helped me along the way is, once again, getting out there onto the units. What are the kids using? Going into the classrooms, what are we sharing? What are we doing? And then sometimes there was things like wood blocks that I kind of get, but at the same time, like, I don't know how we can really clean those things. So if they're not like one patient use, like, I'm not sure that there's a way around it, but can we get another kind of block, that's similar that we can wipe down? So you need to look at the shared items. Puzzles are really good for your brain, whether you're a geriatric patient, right, on my geriatric unit, or you're a child or you're an adult. We all love puzzles. So having my behavioral health background, I'm like, oh, I don't want to get rid of puzzles. Like, I get the importance of doing these group activities. I understand, like, we need patients to recover. We need to teach them how to socialize with other, right? So, like, it's everything against, like, infection control. That, like,
there's a collective gasp. by the IPs watching at this
We,
point in time. Yes.
we want them to be together. Oh, and by the way, let's just throw in the fact that hand sanitizer is really, really difficult on the units because you got patients that can chuck it at each other. You got patients maybe could squirt it in your eye. You've got little kids that if they pump the thing and they're underneath it, it gets in their eyes. You know, you got kids that are pumping it. It's going all over the place, right? And people are slipping and falling. I'm telling you, this it's just, you know, it's stressful. So a few things that I came up with for shared items. I didn't really want to get rid of puzzles. So my recommendations for things like puzzles and books would be before people are using these things, squirt some hand sanitizer on their hand. I cannot control people touching their noses. So there's going to be a level of you're going to touch something and whatever. But we do really, really, really need to have these things for these patients to get better. Okay. You cannot, these patients don't have TVs in their rooms. Okay. They don't have anything. We have reduced the stimulus for them because they were out in the world and they were overly stimulated. Right. And so now they're here. So we still have to provide that therapeutic milieu. We still have to provide therapeutic activities for them so that they can get well and get better. And so it's really hard. I'm kind of a by the book IP because I have learned and I'm very humble and I don't know it all. And sometimes being by the book is just, it's easier. We'll just isolate the patient. That's what you got to do. Just keep them in the room. Do a one-on-one, keep them in the room. But you know what? That's not, I'm kind of going all over the place. I'm sorry. But that's not like ideal for the patient that is suicidal, that we need to keep from isolating themselves, right? So when with the shared activities and the group activities and trying to minimize the spread of germs, I talk about cleaning hands before and after. I talk about if the thing looks dirty, you got to toss it. You got to get rid of it. We can't keep it here. I talk about before group activities, we need to monitor patients. We need to ask the questions, or observe, are they sniffly? Are they sick? Are they starting to be symptomatic? We need to early on identify, you know, what we're doing. Can we use dedicated stuff? Like, do we have to share the markers? Can we afford to get everybody their own set of markers? You know what I mean? Because I know that cleaning, if we can clean them, that's great, but
Maybe wants to clean a bunch of markers.
Yeah, I feel like that would really impact workflow because that's another thing you need to think about, right? Even as in the acute care facility, we're coming up with processes and implementing changes. It's important for me to talk to my staff. Hey, we're going to change over to this pocket kit. Can you try this out and tell me how this is, you know, I'm not changing central line dressing changes, right? Tell me what works for you. Tell me what you don't like about this. And then I can bring that back and see if we can make some recommendations so that you do that same thing in behavioral health, right? Because there's all of these different things. The kids need toys, the kids need books, you know, they need classroom time, whatever. But in general, those are just some of the things to think about in terms of, you know, group settings, activities, and items, shared items.
I think you bring a really good point. Like you have to think out of the box. You can't do a one size fits all for, and even what worked on one pediatric unit might not work on the next, or one adult unit might not. You have to just adapt. And I mean, I feel like I'm going to harp on this, but again, you're doing a risk assessment there. Like what is the risk of if we clean their hands and they go work on a shared puzzle together? What is the risk? What is the benefit? And those kind of things to determine like, oh, this is an activity we need to keep. Here's the risk, but this is why it is necessary.
We had children who had autism and different developmental disabilities. And so we had things like sensory boards. So what do you do with these sensors, right? They're constantly being touched, but even that, we have to think about the cleaners that we're using, right? So the kids, we're cleaning the sensory wall, then we're touching it. I'm a child, and then I'm touching my mouth with residual like disinfectant on it, right? Once we figure out, are we cleaning them, and we come up with that frequency of cleaning, I'm like, okay, so we disinfect it with our, you know, FDA approved cleaner to make sure we kill all the things that we're supposed to kill. And then we need to wipe residual chemical. I know it's not really an IP thing, but we need to wipe residual residue off of that so these kids are not getting reactions.
Something I want to touch on the environment. You mentioned a little bit earlier about like the Legionella with the slower water. Something also to do with water. You're doing laundry. That's not medical grade laundry. most likely at a behavioral health facility, at least at a standalone one. Most likely it's not going to be medical grade laundry. Sometimes if you have different types of, depending on the facility, people might be doing their own laundry as well, depending on the different environments. And something to note is because of the self-harm risk, water temperatures are like under 120 degrees, also in healthcare settings too, because of the potential for burns and scalding and whatnot. So that itself poses a risk of having your waterborne pathogens, because it's giving that nice little like lukewarm breeding ground for your biofilms and all the lovely germs to hang out.
So one thing I want to really stress, if you're an IP in behavioral health, so in addition to the community nursing that I did for behavioral health for many, many years, I decided to work at another inpatient psychiatric facility as a nurse so that I can learn what they go through, and so that I can kind of think out of the box for them, right? Not for them, but like for these weird situations that we come into. And I have a lot of contacts at inpatient behavioral health centers just because I work in behavioral health, and talking to a lot of people that cover infection control at those facilities. There is kind of a lack of, I kind of want to say support, just to be real and honest. There's a lack of support for education and infection control. I don't think that these behavioral health facilities truly understand what infection control is and why it's so important for that person to know these things, to be able to do these risk assessments, to be able to mitigate the risk of having a large outbreak. See, a lot of these places don't have a dedicated IP. They may have just had somebody turning in like their reportables. I have seen their IPs pulled to the floor to work on the floor. There is a lot of focus on employee health, right? But there's not this focus on infection control and the things that we can do. So what we tend to see is employees and patients just sick and running around everywhere. So the reason why I was saying all that, sorry,
No.
I circled all around there, is because working in that setting, I want to stress, if you are an infection control nurse and you work in a behavioral health setting, you still need to have a water management plan. You still need to be looking at the water testing and like the temperature. You know, are we doing the things for the temperature? You are not required to water culture, right, per se, by our like regulations, but what are we doing here? What are we doing here to mitigate those risks for Legionella, right? And so you should be working very closely with your facilities manager, with your EVS perhaps person, right? Because do we have a closet randomly somewhere not being used, just building up biofilm and Legionella? This sink probably needs to be flushed, right? Like regularly. So, and I will tell you, these buildings are old, and especially if they don't have an infection control nurse or they're not used to that, we need to be looking at some of these things because they might be at an even greater risk because now we've got these, you know, ligature free like faucets and things like that. So it's still very important for you to be a part of those WICRAs, as CDC calls it. That's what most of us use. That's what a lot of people use. And doing those assessments on those units, in those hallways, in those buildings, knowing where your risks are, working with that water management team. If you don't have one, you build a team and you kind of go from there.
So now that we know about the people that we see in behavioral health and the environment that we have, what would you advise to someone who is brand new as the IP in a behavioral health facility? What do they need to do first day on the job?
I mean, first day on the job, you need to start making friends. You need to make friends with your employee health nurse. You need to start getting buddy with your engineering. You need to get tight with your EVS. You need to get in with your CNO. Your CNO is going to help you make changes and really help to support you. I personally, I know everybody has a different personality. I might.
You're very introverted.
I'm very extroverted, but when it comes to my job, I'm like a little different. But it might be because I do have a psych background. I don't really want to stress people out, and I want collaboration. So I probably should be a little bit more assertive at times, but really I have this kind of softer approach, kind of like, don't just want to be on your unit when I have something to tell you. Like, I want to come and like, hey, what's up? How y'all doing today? Is there anything you need? Like, I don't just want to be on the unit to be like, hey, we have a problem, guys. I need you to work on something, right? So just trying to develop, you need to develop your relationships with your people. You cannot do this job alone. You cannot be an IP by yourself. It doesn't matter what your behavioral health or acute. I call Rochelle. I call everybody. Okay. If you give me your number to ask me a question, I'm going to keep it for myself because I'm going to find something that you're good at and I'm going to call you when I run into it. So that is really, to me, the biggest day on your first day is trying to get to know who those support systems are for you. Make friends, even if you're not a friend person. If you're an introvert, my husband's an introvert. He you know, he's extroverted because of me, because I take him out and he gets to meet people and talk, but he's more like introverted. If you're introverted, just, you need to make friends. Like, even if you don't want to, make friends.
And it'll be very helpful in understanding the workflows and the different things that you're going to have to work through as an IP, because if you don't have that behavioral health experience, then a lot of the way things are done or the issues that come up are going to be foreign, and you don't need to act like you know how to do everything. You need to let the people who do the things tell you, so you can be more, it will make you more effective as an IP, and then also make everyone safer as a result.
And, you know, part of that making friends per se, like, is making yourself present, doing a tour, walking around, getting to know like where things are at. Like, that is super important. And honestly, I this is probably a lot for first day. Let's just change it to first week. Trying to know what policies you have that could potentially support you. Oh, and your house managers, 100% make them your best friend, because they're going to be the ones you're going to say, hey, if things go down at 3 a.m., this is what I need you to do right here. Because that's what they are going to be, the ones that are getting that unit prepped, educating, like, they're going to help you out. You need to make them your best friend, especially in the behavioral health setting. Construction and renovation is just one thing also for people to know about. So in a behavioral health setting, we cannot use things like edge guard or plastic barriers a lot, right? Because patients can take these things down. They can use them to hurt themselves or others. So one thing you could see is barriers actually being built. It takes a lot of extra time and it's a lot of extra messy. And so there's things like that, just to note. There's other times where I have to be a bit flexible. So I'll give you an example. On our unit here, they had to do some bathroom renovations after the unit was built. There was some issues with the sloping. And so I had to think through, like, first of all, no, we're not going to put a barrier up or use plastic in where the patients can get to it. I needed to think through about, when you guys bring your stuff onto the unit, it needs to be like in something covered. Like, we cannot have like just tools and things like, you know, out there. So just making sure that you're looking at some of those things, communicating with that staff, making sure they know when people are going to be coming. They can coordinate when the sense is a little bit lower, maybe if it's not like a rush to do it. But also, just like what we did in this case, is they closed the door, they put the sticky mat inside the patient room. Of course, they're locked in the room because they're doing stuff. And we plasticked like the bathroom because that's where the work was being done. But it's just making sure you're thinking through some of those processes with construction and renovation.
Yeah, very good points, because construction's already not in a lot of people's wheelhouses to begin with. So add
Yeah.
this other element and makes it really fun.
Yep.
So let's do isolation precautions. Like, how are we going to handle when people have infectious illnesses? What do we do?
You know, I worked on a lot of data, and I would admire all these IPs that they'd be like, oh, the flu, the incubation period is 24 to 48 hours and this, and everybody knew all this stuff. And I'm like, I'm just here working on data. And I'm like, I don't know how they know all this stuff. And I'm sitting here, whatever. Well, guess what? I went to behavioral health and I can probably do really well on my CIC because of incubation periods. I seen everything there. I mean, a lot of stuff there that, you know, we ended up having and stuff. You need to know, my first thing when it's something I'm not fully aware of. So for example, I got the question like from the other IP at the other hospital, like, will your unit accept them if they have human metapneumovirus? And I'm like, well, you know, tell me a little bit about this patient. So some of the things that you want to know when you're making some of these decisions is symptom onset, when their symptoms started, right? Because I could test today, but maybe their symptoms started 5 days ago, right? And so depending on what we're working with, we may not have to isolate for the full like 7 days or something, right? Depending on what we're looking at. So you need to know when their symptoms started. You need to know what their current symptoms are. Are they snotting, sneezing, coughing? You know, do they have a fever? Like, so we want to know how sick they are essentially to determine precautions. And then you need to learn about that illness. So what's the incubation period? When are they contagious? How long can they spread these things? And then you got to come up with something that's going to work. And you've got to look at the behavioral health stuff too. My gosh, I'm going to tell you a quick, I'll try to make it quick, but like we think about cohorting sometimes, right? Let's say we have an outbreak on a unit and we think about cohorting and you're like, oh, these 2 patients have flu A. Well, just put them in a room together, right? Because we're trying to maybe keep the unit functioning. We're trying to mitigate the spread. Let me tell you, behavioral health will throw a wrench at you, okay? No, you can't put those 2 together because they were fighting just yesterday. No, you can't put those 2 together because one of them sexually assaulted another kid maybe. Do you know what I'm saying? So that kid can't be put, you know, so it's just, you got to, there's so many things that are challenging about determining this kind of stuff, but you have to look at all of it. And that is the more reason to become friends with the nurses, the techs, the CNO, everybody, because you're going to need information to make your decisions. What I do is all of that. So I get all of that information. So I talked to the DON and I said, what are they coming in for? And, you know, she gave me the safety issues and it's something that we probably don't want them stuck in the room for a long time. And I said, I need to know what the symptoms are, where are they at with their symptoms? And then I need to know when the onset was, if we can get that. That's another problem with psych. Some of these patients, they can't answer these questions. They don't have family to answer them. We don't have a good medical assessment. So we just have to do the best we can do. So my recommendation was, after I looked up the illness, I said, ideally, we would want a patient who was symptomatic, very symptomatic, coughing, sneezing, you know, fever, all these things, to isolate at least, I would say they would need to be symptom-free for 24 hours, right, before they're coming out into milieu. However, guess what happens? You might have a patient isolate for a day or 2 if you're lucky. Sometimes they won't isolate at all. They're going to end up coming out into that milieu because they got nothing in their room. I'd probably do the same thing. I'd probably be out there coughing, sneezing, messing everybody up. And I'm mad because I've been forced to be in a room. So in addition to what my ideal recommendations are, here's what to do if the person doesn't stay in their room. So for this particular patient, if this person doesn't stay in the room, let's try to see if they will wear a mask. We can offer but not require other patients on the unit to wear a mask. We want to keep socially distanced as much as possible. If we do group activities, in addition to being socially distant, we want to have dedicated like supplies for that patient, you know, markers, whatever you all are doing, just have it for them. We want to increase the cleaning of things on the unit in shared spaces, items, etc. while this patient is ill and walking around. We also want to, you know, clean our hands and hand hygiene, which let's just run into that really quick since we're talking about that. So a lot of behavioral health units, they have the hand sanitizer behind the nurses station. So, you know, we can't have just like cleaners hanging around or anything like that either. So it makes it kind of hard, I think, for me as a staff member to encourage them to have hand hygiene and for me to have hand hygiene, right? Because I'm down the hall, the nurse's station is all the way over here. And now I've had to touch this patient's environment. I've had to touch them maybe because maybe we're in a management situation. There's no way I can clean my hands by going all the way back over there. So what worked for me and what I'm going to also maybe try to work on over here and what has worked for some other settings, I went to APIC National a couple times and I've kind of listened to the behavioral health, is like trying to have maybe like a smaller, but like a small hand sanitizer like this. It's a very small amount. So if they drink it, hopefully they're not going to get their hands on it. But if they were to drink it, it's a small amount. Have it on you and in a way that it's attached to you. And so I kind of come up with like a little way of doing that. And I tried it myself when I was working as a nurse, and it was super effective. And like I was even able to clean my patients' hands, like squirt it out into their hands when they needed it. And so that would be kind of my recommendation, because doing something like that where it's on you, you're not like, you don't have it in your pocket, you know, it's like clipped to your pants or it's like clipped onto you somewhere so that you're not like leaving it behind in places, because that's the biggest thing with the hand sanitizer. We don't want to leave things like this for them to drink or throw at people or, you know, break it up and make a weapon out of it.
More thinking out of the box, because it is going to be a little bit more difficult to do the right thing to get to the hand sanitizer or whatnot in this type of environment. So you definitely have to think of what can make it easier access.
I will just say this one thing about hand hygiene. We do monitor on our unit. So there, that comes up as a question sometimes. Do you monitor hand hygiene on behavioral health units? Yes, I did it at previous facility and at this one.
Yeah, because you still want to, you want to know if people are doing it or not, because it definitely will impact transmission. So let's talk about congregate settings with TB and why is there a higher risk in this type of environment for TB spread?
Well, I mean, basically, it is where your patients are coming from. I mean, they're coming from jails. A lot of our psych patients, they come from prisons, jails, homeless shelters, just high risk TB areas. And then, of course, just looking at the incidence rate of TB, like in your county, state, you know, nationally, like doing that comparison to see where your risk is at.
And what is the time? It is the time period. I can't say I've looked it up recently. It's like what, 8 hours of exposure, I think,
Yes,
of
yes,
being with someone who has TB. So when we're in those repetitive communal settings, then you can have this, you be exposed to the same person with TB multiple times in a 24-hour period and hit that 8-hour mark rather quickly.
yeah,
So that makes the spread way easier than like if you're in a healthcare facility and you have your negative pressure room or whatever.
oh,
So why it's very important to know and pay attention to the symptoms and the exposures and those kind of things on admission and then continually as they're
right.
admitted.
Well, and that's the thing too, like we don't really have negative pressure rooms
Right.
in our behavioral health unit. I've always felt like we probably should consider at least one negative pressure room. But you know, it is what it is. So you just have to do your best with what you got.
Yeah.
As much
Right.
as healthcare is.
And so with the people who work in these, like talking a little bit about, I'll just dive into like occupational health. You need to make sure to include pretty much all your staff in your TB plan and your TB screening and those kind of things because of the high risk environment. All the people that are healthcare workers need to be, basically anyone that sets foot in your building needs to be able to, they're an exposure risk to TB, and we need to make sure that you're screening, doing risk assessments, and assessing for potential conversions and things with TB tests as well. We
Yeah.
could go into a whole other discussion about that. So we're not going to dive into TB because I want to hear, as kind of our final wrap up topic, I want to hear about your lovely experience with COVID and working in behavioral health, because I know you were in the thick of it around then and having to deal with patients and figuring out what units to shut down and those kind of things. So I really just want to know about your experience, because with COVID, it can apply to basically like your other respiratory illnesses too. Some not necessarily as extreme, but some of the things that you would have learned or utilized through that experience with COVID can spill over and apply to the way you kind of go forward and treat different infectious diseases, or if we get some crazy special pathogen um, in the future. So let me just hear about that, because I think people will find it very valuable.
So I think the unique thing about COVID is how contagious it was. And so a lot of the times, if again, the screening, so we had a couple situations, we had a situation where a patient was screened. Like, we did all the things the right way. It was amazing. It was amazing. So like, the person came in, they were symptomatic, whoever was working right away stepped up, got their PPE, like that employee put their stuff on, asked the patient to put a mask on. The patient was compliant, right? Or I hate to say that word compliant, but cooperative, really. And so that patient, we knew had COVID coming in. Anyways, we knew right off the bat that this person, we tested them, they had COVID. And so we brought them onto a unit. And so we don't have an exposure yet per se, because the time frame and all that stuff, like, we're good. We looked at the unit. It didn't have as many patients on it. We were lucky it was like an adult unit too, so that's a little easier than kids. They're a little bit, in a way, more not controllable, but like, you can talk through with processes and say, hey, can you do this, and can you stay away? So that patient was put in the front, a room in the front, and we had like 4 empty rooms in the front, and then the back half had like rooms. So the rest of the patients stayed in the back half in those rooms. This patient stayed in the front half. And so the unit did not go into diversion because we had no exposure at that time. I went onto the unit. I'm not afraid to go into the behavioral health unit. And I met with the patient, and I had conversations with him. And I talked with him about what we were doing and why we were doing it. His big concern was he wanted to be able to like use the phone to make phone calls. Totally understandable. He would want to maybe come out, maybe like for a minute to, I don't know, maybe sit at the table or something. Said, okay. So what I had to do was work through that process with him and the staff. So we found a space directly across from his room. He would use hand sanitizer. He would mask up. He'd go make his phone calls. That space was not going to be utilized for anything. It was kind of like a social worker room, but they had another one, so we weren't going to use that room for anything but him. And if he had to come out of his room, he would mask up. This worked out really, really good. He was able to isolate. Another thing that I brought up, not an infection control thing, but behavioral health background. Whether somebody has COVID or norovirus or whatever they have, and we do ask them to isolate, like, we still need to bring our therapeutic, our mental health services to them. So we have the appropriate PPE that we can put on. We can still go into their room. We can still have conversations. We can still do activities with them. And that is something that really needs to be stressed, because again, they don't have things in their room. So you're going to get bored and you're gonna be like, let me out of this place or I'm gonna lose it. You know what I mean? So if we can bring those things to them, if we can use things, for example, like a tablet, right? So if it's safe for them and they can have books or a tablet or anything like that, use those things. Group activities, they can participate. I know they won't be there, but let's do it on the tablet. They can be a part of that group activity and do it in their room, and do it like by Zoom or whatever you want to call it, virtually.
You bring up a good point. It's very important to remember that the people we serve are just that. They're people. And they are human beings first. They are not their mental illness. They are not their physical illness. They are not their contagious illness. They are people first. And we have to treat the person, think of that before we get to the other things that impact them. Because if we take that out, then we would just lock them up and shut the door and be like, they're not getting anyone else sick. But we have to remember they are people. And so they need to make those phone calls so they're not completely bored while they're there, feel lonely and more isolated than they probably already do because they're in a strange setting anyways. So very good points of like you gotta still consider them as a person first and make sure they still get their services and they are getting treated the right way, and while keeping everyone else safe at the same time.
Hmm. So, on the other hand, here's another thing. You have visitors and stuff. And so during the kind of the height of COVID, like visitation was restricted and things like that. And I was kind of there on the end of it. When I came in, we were looking at modifying visitation. It was kind of during like the Delta wave, Omicron. And so you've got people that are coming from the community and we're kind of bringing stuff in that way. You've got employees coming in and we might be bringing in stuff that way. And so we definitely had some COVID outbreaks on the unit. And so I'll have to talk about it in adult versus children because there's a couple different things to look at for that. So with adults, what we would do is as soon as we knew somebody was sick, we would try to isolate. That took a lot of education with the staff and I would tell them, look, if you can't, you can't. I mean, I don't want you to get into a power struggle with the patient, right? Because we know what field we're working in here. Right. But try to see if we can get that patient isolated. If we have a private room available and their roommate is not symptomatic, let's try to get, let's try to get that patient in a private room. Let's try to get their roommate in a private room. We had units that had shared bathrooms too. That really kind of posed a little bit of an issue as well. But we would test that patient. If they tested positive, then basically the whole unit would test at the time. So we would try to isolate everybody to their rooms until testing came back. Sometimes that worked, sometimes it didn't. Sometimes we would ask if they would want to wear masks if they weren't isolating. Some people would do that, some people wouldn't. You've got people in behavioral health that are very paranoid. And I get this, they want to pace and trying to stick that person into a room that has that level of like paranoia and anxiety is going to cause a lot more problems. So once testing came back and we could determine, how many people may be positive, then we would kind of go from there with what we needed to do with the unit. Some of our units had doors that split off like a back half and a front half. Other units, we didn't have that. So what we would do is, let's say we had 3 people test positive for COVID. This unit probably more than likely was going to go on diversion. Anything with COVID, it was like anything more than 1. With other disease or infectious diseases like flu or something, we would do 2 or more because 2 or more is outbreak, with CDC. So the rooms the units that would have doors on them, what we could do is anybody that was positive for COVID would be on the back side of the unit and there was doors. And so staff would gear up when they would go back there, take care of them. We were very lucky because it would have like their own dining room, it was nice that we could split that unit up. Not a lot of places don't have that opportunity. It's just one unit, just like this one here. And we don't have doors or any way of separating anybody. We would always put patients that were positive in the back of the unit so that we're not walking through, like walking through the
yeah, like a clean to dirty flow instead of a dirty to clean.
Yeah, because
flow.
like we don't know if patients are going to like stay in the room anyways and stuff. We just don't know where things are going to go with that environment and stuff like that. So there was a couple times where we were able to put that unit kind of on diversion because we had enough patients that we could have them on the backside and we can open up the front side to like new admissions. Does that make sense? But again, we would have the new admissions in the front because we don't want them walking through like, that hallway where the COVID patients with COVID were at. Now with kids, it was different. It was same setup if we had diversion of the unit, but they went to school, remember? So if they were on diversion, and I hate myself for this every day, but they weren't allowed to go to the playground, which I really hated because they won't keep their mask on. I mean, like, I'm saying to walk through the hospital.
Right.
Clean their hands. They're not going to keep the mask on. The thing about it is, it's just like, I couldn't. I was like, I don't know. I think they need to stay on the unit. We didn't send them to school. Also, like, our teachers were not N95 fit tested or anything like that. So that was like another reason they couldn't go to school, because those teachers were not. So what would happen is they would have like tablets, they would have like booklets, and so the kids would do school. It sucked for them, I know, but they would do it on the unit for that time frame. Isolation at the time, like if we had a unit on diversion, and I'm not sure if they still do it the same, but at the time, what we would do is 5 days for the unit to be diversion. On the 5th day, unless somebody was symptomatic sooner, we would kind of test all the patients, we'd assess, make sure no one's symptomatic. If all of that was good and clear, we'd reopen up the unit and make sure it got cleaned well and everything like that. And that's for anything, norovirus, anything that maybe they've been shut down because they had like so many people sick on the unit. We'd make sure it get cleaned really well and then reopen. But just one more thing on COVID, I just thought now. We had our PPE set up outside of the unit for those that went onto the unit so that they could gear up, put their stuff on before they went onto the unit, right? Because our patients are mobile.
Right. Yeah.
So like if they had COVID and that unit's on diversion, we're not keeping them in their rooms, right? Like they're walking around and stuff like that. Now the patients who had COVID, like they tested positive for COVID, they would isolate them as much as possible, but we still had all these that were exposed. They tested negative, so we're trying not to keep them in their room. They're walking around, but we just don't know if they're going to become symptomatic like today, tomorrow, the next day. So we required our staff to wear their PPE on the unit. We did not require, although we would provide gowns for the staff. I didn't enforce it 100%. I wanted them to do eye protection, N95, and gloves, whatever contact precautions. But the gown, it's like with them having to do management and a lot over there, like I could just see that creating extra safety. Once again, that risk assessment, extra safety issues for everybody on the unit. So, but just thinking about, it's a congregate setting, so you can have an exposed patient like just circling right by that door. So just making sure your PPE is like outside of the unit so that people can guard up before they go on.
So thanks, Natalie. What would, just to kind of put it all together for the people watching, what's like one last piece of advice you'd want to give to an IP working in behavioral health?
I mean, I just think really like you need to know your land, know your layout, understand what is happening in your facility, and you need to make a team. Like you need to have a team, because there's a lot of different things that get thrown at you in behavioral health. And the biggest thing is everything. It literally feels like this. Everything is case by case basis for behavioral health. Nothing is like, hey, isolate them for 48 hours and I'll update the banner. No, it's not that. It's always something. And for those of you, I am very grateful. Private rooms, private bathrooms here on my units. But for those of you who have those kind of shared spaces, like it really makes it difficult. So you don't have to be friends, but just make your team, build your team, and you'll get through it.
So if you would like an exciting career where nothing is the same any day back to back, then be an IP in behavioral health.
Your hair becomes behavioral health.
Yes. Well, I just want to point out a couple references that I used today. The APIC text has a behavioral health chapter, and then they also have on their infection prevention and you website a behavioral health little kit. And on the YouTube series page, if you go to our Beard IP, you can access the resources used for the Let's Talk About It episodes. And then also, if you need to contact me for any of your IP and QI consulting needs, you can email me at rochellebeard@outlook.com. And if you have any questions for Natalie, you can email me there and I will make sure to get them to her.